Hi, my name is John Stulak from the Mayo Clinic in Rochester, Minnesota. I'm very honored to give you a talk today for the Society of Thoracic Surgeons. My assigned topic is post-cardiotomy ECMO support. I have no disclosures. So the broad indications to consider extracorporeal membrane oxygenation support really breaks down into two patient populations. Those undergoing cardiac surgery, both for pre-op stabilization, failure to wean from cardiopulmonary bypass, post-op cardiac, low cardiac output, post-op cardiac arrest as a salvage maneuver, and those not undergoing cardiac surgery. So arrhythmias, myocarditis, and then respiratory failure like ARDS, and most recently COVID, et cetera. But we're going to focus on this first group of patients, those undergoing cardiac surgery. And within that subset of patients, we're going to focus on post-cardiotomy. So after a conventional operation has been taken and you're not able to wean from bypass. So really, these patients can fall into two categories. Is it a circulatory problem or is it a pulmonary problem? So sometimes patients, after long bypass runs, high-risk cardiac surgery can have isolated lung problems and their heart functions just fine. So in that situation, we would consider Venovenous ECMO on the left-hand side of the screen. This provides respiratory support only. Your outflow is either from the vein or right atrium, inflow being the vein, right atrium, or pulmonary artery. It maintains pulmonary blood flow. You do get a lower systemic PaO2 with this because of flows, and the lungs are not working. And the ECMO circuit is in series with the heart and the lungs. Now, if it's a circulatory problem, let's just say the lungs work well, but you're choosing to just put in an oxygenator and just do full Venoarterial ECMO support, this gives you respiratory and circulatory support. The outflow is from the vein or the right atrium, inflow being the artery. This bypasses the pulmonary blood flow and decreases PA pressure, so it really does decompress the pulmonary bed as well. You do get a higher PaO2 that's achieved, because there is still native ejection from the heart and the lungs are working. And in this configuration, the ECMO circuit is in parallel with the heart and the lungs. So really, I'm going to go over several different considerations for cannulation sites. So let's just say your patient came off, had lung injury from a long bypass run, and you want Venovenous ECMO. Well, this is readily achieved through percutaneous configurations, and you're able to close the chest. So shown here, you have two-site Venovenous ECMO, where you have a femoral venous cannula, goes into the ECMO support through the oxygenator, comes back in through the right internal jugular vein. And as you can see here, you do not want your cannulas too close together, or you'll just get recirculation. It'll come in from the oxygenator and go right out of your venous cannula. But however, if you have this, the lower outflow cannula, low enough at the RA IVC junction, you will get good flow. The majority of your blood flow will go through the tricuspid valve. So this is the two-site Venovenous ECMO. And as we all know, the Avalon cannula is a single cannula with a dual lumen. Basically, position also is very key, where you get outflow from the deep IVC and the SVC, and then you want to position the inflow basically facing at the tricuspid valve. Now, let's move on to Venoarterial ECMO. Let's say you come off, there's poor ventricular function, it was a high-risk cardiac operation, or there was an intracardiac misadventure, or something like that. There's, again, several different configurations. However, this gets a little trickier. So if you're really interested in closing the chest, there is peripheral cannulation potential, where you have the femoral artery and the femoral vein. So the femoral vein being the venous outflow, and the inflow being the femoral artery. In patients, if you directly cannulate the artery, again, you want to consider a distal perfusion cannula shown here, which is then wide in and you distally perfuse. You could also consider a chimney graft on the femoral artery. And as you can see here in this picture, this does allow a little bit of a phenomenon, a watershed type phenomena, which we'll talk about. You could also, if you, to get rid of that watershed phenomenon in mixing, you could put a chimney graft up to the subclavian artery and then venous outflow from the right internal jugular vein. And here you get antegrade perfusion with oxygenated blood. And again, this allows you to close the chest as well. Now we're going to look at central VA ECMO, and this is our preferred approach. If you have an open chest after cardiac operation, we prefer to maintain central cannulation. You can tunnel the cannulas, and if you feel like it's going to be extended ECMO support, you can tunnel the cannulas and even close the chest to allow for extubation and ambulation. However, typically patients recover in the first 3 to 5 days. But here you just maintain central aortic cannulation and right atrial cannulation. And here this gives you full flow, full decompression of the heart with oxygenated blood going antegrade. Now, peripheral ECMO for the for cardiac dysfunction coming off of cardiopulmonary bypass, I think, it's my opinion, is bad for 2 reasons. One is that you do have this mixing of deoxygenated blood in the ascending aorta. And you have retrograde flow. So retrograde flow actually increases afterload against a poorly functioning ventricle. So if you are hoping for LV recovery, then having retrograde flow and increasing afterload of the left ventricle is not a good idea. The second thing is you do have this watershed area. And so deoxygenated blood right here is bathing the coronary arteries. So you're depriving oxygenated coronary arterial blood flow to a very poorly functioning left ventricle. So peripheral VA ECMO for post-cardiotomy settings due to failure to wean from cardiopulmonary bypass due to LV dysfunction, I think does not suitably optimize your ventricle for recovery. If you really do want to go peripheral, we do have what we call Java ECMO. It's jugular atrial venoarterial ECMO. Here you can see that we can come up from below in the femoral vein and do a transeptal puncture in conjunction with our electrophysiology colleagues, and we can have a decompressing cannula in the left atrium. We do have systemic venous drainage through an venous cannula, and then we can either cannulate or put a graft on the subclavian artery so we get antegrade blood flow. This does allow you to be completely percutaneous and close the chest at the same time. So this is a configuration that in conjunction with our interventional cardiology colleagues and electrophysiology colleagues that we are going to more so. Or if you wanted to do a different configuration for LV venting that is readily obtained with an Impella device shown here, you could have a pulmonary artery catheter for outflow here, and then a femoral venous cannula for systemic outflow. So there's many different configurations. If you wanted to go peripheral, we do recommend one of these innovative configurations rather than simply right artery and vein configuration. I do think that venting in the setting of post-cardiotomy ECMO is very, very important, especially when there's poor systolic function, which is typically the issue when you need post-cardiotomy ECMO, and when the LV EDP is high and you get LV distension. I think there's a misconception when you put the patient on VA ECMO that you're completely supporting the left ventricle, and that is just not the case. You can get pulmonary edema and really put a lot of pressure on the failing ventricle and the failing lungs if you do not vent the left side of the heart. So we do suggest maintaining an LV vent if you're centrally cannulated, or like I said, you can use an Impella if you're peripherally cannulated. But LV venting is a very important adjunct if you want to have LV recovery. And then once you get into a situation where you're a couple of days down the line and you're trying to wean the patient and you can't, it's always important to debrief and go down a checklist. Here we go. The reasons why you'd be failure to wean. Are there electrolyte problems and miscellaneous issues? Are there, mechanical issues like undrained pleural effusions? Are there residual valvular issues? Is there new aortic regurgitation? Is there new mitral valve regurgitation that's inhibiting forward cardiac output? Is there obstruction to flow? Are your cannulas well placed? If you are doing congenital operations, are there residual shunts that is not allowing forward cardiac output? And then other things like, is there bleeding? Is there outflow obstructions? God forbid a dissection or anything like that. Are you optimizing the pulmonary conditions with ventilatory management? And then obviously other things like inotropy and chronotropy are very important. So you really want to go down a systemic a checklist as to why you may not be able to wean from cardiopulmonary bypass. And looking at the algorithm, if you're 2 to 3 days out and cardiac function is returning, then that's great. That's a bridge to recovery. However, if you're not, then you're looking at a more extended period of time. And then this is where you, can engage your palliative care colleagues if it's an elderly patient, and they're not a LVAD or a destination LVAD or a transplant candidate, then perhaps it's something like comfort cares and consideration of withdrawal of support. But this is something only after several days of optimization and recovery. So in terms of our philosophy, in terms of post-cardiotomy configurations, we prefer to maintain central cannulation. You can tunnel the cannulas, and if you really want to close the chest for an extended period of time, have the patient get up, walk around. And we're really, if it's within a couple of weeks, in opening the sternotomy back up and decannulating is really not that big of an operation. LV venting to optimize LV recovery. If you have LV distension, you're not going to have LV recovery. That's the bottom line. We do, if there's some intrinsic LV function, we do suggest maintaining pulsatility, especially in a patient where prosthetic valves are present. And because we've had thrombosis of even bioprosthetic valves, but certainly if there's mechanical valves present, you want to flow optimally to maintain pulsatility. And then you want to plan for a slow, deliberate wean. If you put on post-cardiotomy ECMO, do not be in a hurry to get off the ECMO in 24 or even 48 hours of support. Sometimes the investment up front means long-term gain. So plan for, if you want chest closure, even if you're centrally cannulated, plan for ambulation and recovery. But if it's a long-term bridge, some of these newer innovative cannulation strategies work very well and allow you to close the chest. So again, I'm honored to have been asked to present this STS series. Thank you very much for your attention.